international exposure and expertise being a truly global perspective to endodontics. Please join us in welcoming Dr. Anand.
Hello, hello. Can you hear me? Gurur Brahma, Gurur Vishnu, Gurur Devo Maheshwara, Gurureva Param Brahma, Tasmai Shri Gurave Namaha. Guru, the word, comes from two words. Gu stands for remover of darkness. Our teachers, over a period of time, have removed darkness from our minds. I dedicate this lecture to Sir, my teacher, my Guru, Dr. Suresh Chandra, who taught me everything. Madam, teachers, I dedicate this to all the teachers, all the academicians here who are imparting knowledge. We are what we are because of you, and I am what I am because of you. Thank you from the bottom of my heart. Thank you. That's me. My name is Anand. I won't bore you with what I did in my life and how I got married and everything. Let's start with the basics. Finished my MDS in 97 to 99, worked in Bombay 2000 to 2007. I moved to the UK. I did some general dentistry from 2007 till 2015, along with endo. Life started getting boring. I said, in Hindi they say, maza nahi aaya. In 2015, I said, I watched this movie. This was released in the year 2009, but I watched it in 2015. Don't ask me why. The story of three friends who go about setting their dreams. I said, I'll be the fourth idiot. I said, what do? I don't know how to fly a plane. I didn't know how to cook. My wife does it. I said, let's do endo. So I did 2 more years of endodontics, and I said, no more of everything. Let's concentrate on endo. That was a picture taken in 2016, 17. Look at me, don't look at who's behind me. That was a picture taken in 2024. What do you see as the difference? Erosion. So what is success? Cambridge Dictionary says success is you get what you want to get. Failure is you try something, you don't get it. In the field of endodontics, success, also called as favorable endodontic outcome, is no symptoms, no signs of disease, mobility is better, sinus tract is healed, and there is tissue healing on the radiograph. I'm going to rush through it because time is short. We have 2 things we talk about. One is survival, one is success. In endo, we mainly talk about success. Success means a favorable outcome. These are the classical studies published in dentistry. I think Paula Ng studies from the Eastman group. It's one of the most comprehensive studies we always quote. What is the significance of knowing this? So primary endo, as you know, success rate is 80 to 85%. Secondary endo is 70 to 75%. Why do you need to know this is very important? Because you need to inform the patient. You see, discussion between the patient and the dentist before treatment is called consent. Discussion between a patient and a dentist after treatment is called an excuse. Now, what causes success? What gives rise to successful outcomes? What gives rise to failures? We really need to understand. Now, you see, most presentations are about success. I'm going to present this on failures. What I got wrong and how I got things corrected, and I don't want you to do the same mistakes I did in my life. Because, you see, success and failures are like 2 sides of a coin. Success gives you a fleeting sense of joy, happiness, pleasure. Yes, I did it, my endo held. Good. But you don't learn a lot out of it. You actually learn more from your failures than you do from your success. So it's very important to reflect on your own failures. That's how you grow, that's how you evolve. So factors giving rise, 3 factors: pre-treatment, post-treatment. I'm not going to bore you with the theory, I'll just go through quickly and then we'll discuss the cases. That's important. Pre-treatment, what do we have? Age and sex of the patient. Can you do anything about it? No, don't worry about it. Medical health, patients will have inflammatory disorders, patients will come with diabetes. Just ask the question, can you do anything about it? If you can, refer it to a doctor, refer it to a specialist. Can the health be improved? Patient sitting on the chair. You've got to explain it as part of the consent. You've got diabetes, you've got an immunological problem, you've got a problem. Tell them this could affect the outcome. Is that the end of the story? No. You work around it. Now, went ahead. Tooth factors, this is a very important thing. Size of the PA lesion, we know this. Bigger the lesion, lower is the chance of healing, but they do heal. It's not a contraindication. Sorry about my pictures, they're not as fancy, but just trying to explain. Upper two, large periapical lesion. I'm not going to go through the details. Large periapical lesion following history of trauma. They do heal, that's a working length. You see the immediate post-op large lesion. It's healing, they do heal. Don't worry too much about it. One more case, 4-2, large periapical lesion, history of trauma 3 to 4 years back. Conventional non-surgical endodontic treatment, obturation. It's healing well. That's a 6-month follow-up. They do heal. Don't get too worried about it. This patient was a bit of a pain. We get 3 kinds of patients. Difficult teeth, difficult patients, and combinations of the 2. This was the number 3. She went from one pillar to post trying to find. It was a simple case of a large infection related to an incisor. She was just not convinced about it. She thought she had a bony lesion, she had cancer, went from one place to the other. And you tell anything, you explain everything you want, and they'll always have a question mark on the top of their head. They take their time. Simple case. Open, clean shape. I'm not very proud of the 3-1. What did I do wrong? There was a bit of sealer extrusion. Does it actually make a difference? Not normally. I'm talking all this from my personal experience. It doesn't make much of a difference. Technique is very important. It's not something I'm proud of. In Europe, most of the endodontists will say limit your preparation and instrumentation and root filling to the confines of the canal. If you see an American guy, they'll say, yeah, that's good, that's cool. That means you've gone through the apex, it's all nicely sealed, yeah. But I personally don't believe in that. According to me, keep it confined to the canal. In this case, it didn't seem to affect. You see, this is 6 months post-op. You still see a bit of sealer cement. That's a 2-year follow-up. I follow up all my patients till they get bored of me. Next case, what do you see here? 3-6 with a large periapical lesion. Tooth was grade 2 mobile. I thought this tooth has to go in the bin. She came to me, she said, Anand, I need to try and save the tooth. I said, I'll try. Not sure. Not sure. It healed. Immediate post-op, 3 months later, 12 months later, it's healing well. You see the bony regeneration there? It's healing well. Sinus tracts, what do you see? We all know what sinus tracts are. That's a classic case. Sinus tract around an upper 2, large lesion, 2. Sinus tract heals, obturate, that's a 6-month follow-up. Presence of a crack. This is my favorite topic, cracks. The problem in the UK is everybody is stressed, everybody is anxious, everybody is grinding their teeth. Lower 6s, lower 7s, you get plenty of cracks. Cracks are very hard to pick, very hard to diagnose. If you're not careful, you'll get into the wrong tooth and create an absolute disaster. This was one such case. This patient came to me with pain in relation to the 4-6 and 4-7. The dentist went, he thought, oh, I'm not so sure, let's replace the restoration. Incidentally, both the 6 and the 7 were replaced multiple times. Restorations were replaced. When she came to me, you can see the 6 had an amalgam, 7 had a composite. You can't see it because I'm on the wrong slide. That's the one. I said, let's get in. Now, for me, it's all about what the patient tells me, what I see, and what I detect has to add up. 1 plus 1 plus 1 equal to 3. If 1 plus 1 plus 1 gives you a 2, you've got a problem. What is the problem? You're missing something. They all have to add up. You see here, the first challenge you have is it the 6 or the 7? Or both? In this case, it was both. If you don't inform this to the patient and you're not thorough with your diagnosis, we often get blamed. The dentist will tell you, he pulled the wrong tooth out. You need to have evidence for everything. In this case, I started with a 7. I said, well, for me, if I'm not sure, remove the restoration and assess. What do you see inside? That's the 7. Remove the restoration, open up the pulp chamber, you see a deep vertical fracture line. What you need to detect in these cases is make sure you probe the pocket around the tooth. If you see a deep crack or a fracture line on the distal aspect of a 7, and along with it, on the distal aspect, you see a deep, narrow pocket, always suspect a fracture. Please be wary, you have to add the whole thing. That's what I said, 1 + 1 + 1 = 3. What the patient tells you, what you find, and everything has to add up. Now, what do you see in this case? Unfortunately, the fracture line goes below the orifice of the canals. The tooth needs to be extracted. The problem is, the tooth was there. Okay, I said, well, go and see your dentist and take the tooth out. She said, fine. The 7 was extracted. And the patient came back to me for exploration of the 6. What do you see on the 6? I removed the restoration on the 6. What did you see? A deep fracture line on the distal aspect of the 6. What was different between the 6 and the 7 in this case was that there was no pocket on the distal aspect of the 6. I thought, well, it should be okay. Went into the pulp chamber, did a conventional endo. There's 2 ways people manage cracks. Some of them do crack chasing, cut the whole thing out, dig, and try and restore. I don't do it unless it's needed. You cap it, restore it, it's fine. This was done normally, did a composite, that's a 6-month follow-up, it's fine. Tooth restorability, very, very important. You need to ask yourself a question, can you get the tooth back to form and function? Can you maintain coronal seal? Can you get a ferrule? If the answer to these questions is no, ask yourself, are you doing justice to the patient by subjecting him to endo, or is it a better option for the patient to take the tooth out? You see, this is a problem. We start jumping into cases where we shouldn't be doing, and we subject patients to extractions on cases which can be saved. Periodontal status, endoperial lesions, patient's not brushing his teeth, oral hygiene is poor, patient's not motivated, you're asking for trouble. Treatment factors, infection control during treatment, rubber dam. The key bit, it is the standard of care. Please don't do root canals without a rubber dam, you're asking for trouble. If you stand in the court of law on a case where the root canal fails, you just have to lift your hands up, you've not done a rubber dam, you are absolutely defenseless. Please don't do it. If you can't put a rubber dam on a tooth, you need to ask yourself the question, is the tooth genuinely restorable? Never do endo without a rubber dam. Let's go through some cases. This lady was 4'6". Now, this was one of my first cases I had. The problem with this patient was she suffered from a condition called Ehlers-Danlos syndrome. Hypermobility, TMJ pain, you had to do it over multiple visits. Short root filling, large periapical lesion. Working length, you do it over stages, master cone, post-op, healed well. Second case, this was an Indian nurse. 2/6 was recently done in 2022. One thing which worries me in this case was there were joint crowns between the 6 and the 7. I really don't know if there is any justification for doing it. What do you see in this case? You see 6, single cone, classic obturation, voids everywhere around it. And there's a big lesion on the 6, mesiobuccal root. You don't need a CBCT, I know what the problem is. It's a poor preparation, poor technique, and a missed MB2. What do? Section it between the 6 and the 7. That's just a GB point going through the sinus tract of the 6. Take it off, retreat it, MB2 treated. 3-month follow-up shows healing. Send it to his dentist and get a crown done. This case is very important to understand because this is one of my failures, which I always teach to my younger dentists because I got it wrong. I lift my hand up and say sorry. Now, this case was, I started this case in 2018. This was a 3/6, patient had a lesion. I did this endo in 2018. I couldn't find the DB2. I said, well, it's all fine. Did a restoration, called the patient up for a follow-up. Patient saw me back after 6 months. Lesion seemed to be healing. And I said, yeah, go and see your dentist, get a crown done. Should be fine. Patient didn't come back to me for a few years. She came back to me in the middle of 2021 with the opposite side. She said, doctor, I have a problem. My dentist has sent it back to you for a root canal on the opposite side. She said, the left side is fine. I've had it crowned. I said, that's fine. So this was the 4/6, lower right 6. What do you see? Large lesion, curved distal root. I said, yeah, let's go for it. Endo done, 2 distals, 2 mesials, distals both are merging together at the apical third, did a composite there. Seemed to be healing well. I said, yeah, go and see your dentist, get it crowned. I thought that was the end of the story. The problem didn't end there. She came back to me 6 months later for the first tooth again. She said, I have a problem. It doesn't feel right. I said, what's happening? She said, yeah, I've got some tenderness. What do you get? Tenderness on the buccal aspect, recurrent periapical lesion. What do you see? I said, oh, that's a problem. That's my mistake. I've got it wrong. Something's not right. What's going wrong? The distal root is showing a lesion. Mesial is okay. Crown is not done by me. It's done by the dentist. What do you see? You see a bit of cement. Excess cement has not been cleaned up on the distal margin. You see a bit of distal bone loss. I said, well, sorry, it's my fault. I'll try and retreat the distal root. I said, well, cleaned up the excess cement, and that's the master cone. And that's immediate post-op. You see a little radiolucency near the cervical aspect. I always put GI under it. It's the second line of defense. There's always GP, GI, and then I do a composite. 6 months follow-up, good healing. It's healing well. She didn't come back as yet. She's fine. This case was a young Indian dentist. He joined our practice. I thought that's an easy case. Yeah. So look simple, arrow straight canals. You don't need me. Easy case. Till I got into the tooth. What do you see? Deep mesial caries, apical periodontitis on the mesial root. Till I got into the tooth. What did you find? 5 canals. 2 palatals merging to one in the apical third, MB, MB2, and distobuccal. That's a close-up view. You can see the 2 palatals joining together. Cleaning protocol has to be maintained. It has to be thorough. Make sure you disinfect the canals well. Master cone, you can see the 2 apices of the MB. Palatal warm vertical condensation, obturated. This follow-up was done 2 months before I came here. The tragedy is the tooth is fine, but he's still not crowned it. It's not my job. Lower 5. What do you see here? Deep amalgam, apical periodontitis. Have a look at the middle third of the canal. You have a look at this. The canal lumen is narrowing down, 1 dividing into 2. These cases are tricky. Be very careful with this because this is where instruments can break. Single canal, if you don't flare up the coronal third, try to do a micro ninja axis, you're asking for trouble. Instruments will separate there. It won't, it might. Master cone, immediate post-op, 6 months follow-up, lesions started to heal. Another one, what do you see here? Again, the bifurcation of the canal. It's bifurcating a bit higher up, a bit in the coronal third. It's a bit easier than that. Working length, master cone. You can see the lesions already started to heal. That's a 1-year follow-up, healing well. Another one, lower 7. What do you see here? Short root filling, fractured amalgam, apical periodontitis, symptomatic tooth, open, clean shape, master cone. That's a post-op. Healing well. Obturation, got to get it right. Absence of voids, make sure it's well condensed. Classic studies of Jogren. As long as the length is correct, make sure the obturation is 0 to 2 millimeters from the apex, gives the best outcome. That's just another case. That's a maxillary 6, some obliteration, immediate post-op, post-op. That's just the different radiographs we need. Avoidance of iatrogenic errors. Things can go wrong. Doesn't always work smoothly. What can go wrong? Instruments can break. This case was referred to me, upper 4. Patient had just had a crown done. And you can see there, apical third, S1 is fractured. What was the fault? The fault is the preparation was a ninja axis, extremely small preparation, excessive torquing, excessive binding of the instruments in the apical third, file separated. What did I do? Bypass, obturate, that's post-op. I don't have follow-ups. This was done 2 months down the line, 2 months back. If you need to see follow-ups, we'll see you in the next year's Alumni Meet. Another one, separated instrument. You can see on the palatal canal, had a crown, apical periodontitis, clean-shaped, bypass through it. Last but not the least, root-filled teeth. Risk of structural failure, make sure you do a cuspal coverage or else you're asking for problems. That's the ESC position statement. Sorry, I'm rushing through, otherwise madam will shoot a gun on my head. Now this last case is another one of our mistakes which I got wrong under patient pressures. You need to try and understand what I did right, what I did wrong. Now this patient came to me in the year 2018. He had, the 2-4 has had a composite onlay placed on that tooth. It was done recently, the tooth became non-vital and referred to me for endo. I had just started my own practice. He said, I don't want to spend money on a new indirect restoration. Can you drill through it? Yeah, I can do it. I said, yeah, that's fine. I'll try and save you some money for the patient. Yeah, that's fine. What did I do? Went through it. That's a midfill, and that was a post-op. 2019 end, this image was taken. Lesion was healing well. I said, yeah, that's good. Problems happened after that. The patient came back to me a year later. Middle of COVID, he said, doctor, I have a problem. What is the problem? The problem is I've got a small lump on the gum. What is the problem? You can see there's a draining sinus tract. I said, no, that's probably the 5. But the 5 was vital. It was the 4 which was failing. I said, how is this possible? How did the lesion heal initially and then fail? Started scratching my head. What did I do? I went in again through the same axis. I removed the GP, re-cleaned the canals, reshaped the canals, and what happened? Nothing happened. The sinus tract didn't go. I just couldn't understand why this is happening. And then I went home and I started thinking, what did I do wrong? Why is this not healing? And then I realized the answer to that question was the previous slide. What do you see on this image? Mesially and distally, there were remnants of the old restoration. So what did I do? I said, come back. Sorry, boss, I made a mistake. Got the patient in again, knocked off the mesial and the distal restoration, cleaned it up. You wouldn't believe it, a week down the line, it healed. What is the moral of the story? The moral of the story is, we often try and help the patient by going through a crown, by going through an indirect restoration, and we think that we are actually doing a service to the patient, but actually we are doing disservice to the patient. My general dentist will refer the case to me and he'll tell him, you go and see Dr. Anand, he can drill through the crown. I'm not trained to drill through the crown, I've got to remove the crown. Is that the right thing? The patient will come and sit on my chair. Doctor, I want you to drill through the crown. I'll say, hang on a minute, let me have a look. Is that the right treatment? No, that's not the right treatment. The patient will say, no, I want to drill through the crown. I don't want to spend money on a crown. So I have a simple analogy which I'll share with you. I'll tell the patient a simple story. I'll tell him, look, you're going to have a surgery on your brain and you're wearing a hat on your head. Okay? You've got to have a surgery on your brain. The doctor has got 2 options. What does he do? He makes a hole through the hat and gets into your brain and seals it off. Or he takes the hat off, cleans your scalp, and gets your surgery done. Which would you like to have? I'm not sure. Second point, you've got a scalp infection. What are you going to do? Oh, take the crown off. That's fine. You need to consent. You sometimes need to talk in the language the patient understands. We often use complex languages which the patient doesn't understand, and we get blamed that we are forcing treatments on patients, which is not the case. Now this case illustrates the same point. Patient has a 5 and a 6 joint crowns, 3, 6. What do you get? Distal to the 6, she had a sinus tract. What do you see in this patient? The root filling is pretty badly done. There's a joint crown on the 5 and the 6, large lesion on the 6. You see a classic single cone obturation, GP hanging in the pulp chamber. It's not been done properly. Easy case for retreatment. You have 2 options. What do? You please the patient by going through the crown, or you take the crown off and do it. What did I do? Took the crown off. That's the same tooth. See what you find under the crown. Coronal leakage. Caries under the restoration. Imagine if you go through this case, go through the crown, what are you going to do? You'll get an endo. Yes, it's fine. It'll look good on a radiograph. It's going to fail. Moral of the story, don't get pressurized by patients. This is my last case, I promise you. Now, have you ever heard of a material called Russian red? Sorry, I was speaking to you yesterday. Russian red is a material used in many of the former Soviet Union states. So we get patients from the Soviet Union states, Poland, Lithuania, where a lot of dentists use this material. Looks very similar in opacity to a sealer cement. It is basically a mixture of formaldehyde and resorcinol mixed with zinc oxide barium sulfate. You take a radiograph, it'll look like somebody has just done a simple sealer obturation. It'll look like when I looked at this case, I said, well, that's an easy case. Yeah, I can do it in my sleep. Till I got into the tooth. Absolute nightmare. Because it'll set like GI into the canals. And once it's in, you're committed to the patient. Yes, I'm going to retreat it. You go in, it's hard work. It's hard work, trust me. It was done. That's the 5 retreatment. 6 was also the same. We retreated the 6 and the 7. That's just another one. That's an upper 4. Just showing you the coronal restoration. Sorry, I'm running short of time. And thank you for listening. Thank you for your patience. I'll end this with a little prayer. Om Purnamadam Purnamidam Purnat Purnamudakshate Purnasya Purnamadaya Purnameva Vashishyate. Om Shanti Shanti Shanti. Thank you. Hari Om.
Thank you, Dr. Anand, for such a candid and practical presentation. The clinical insights you shared will surely help us to refine our treatment planning and execution. Panelists, do you have any questions?
Thank you, Dr. Anand, for a wonderful presentation.